Yes.
And you're seeing, because I have multiple screens, you're seeing the correct this,
Yes,
right?
yeah, I'm seeing the
Okay.
slideshow version and I'm not seeing your notes.
Okay. Wonderful. So thank you again. Sorry I'm off camera, but I have a bad cold and don't want to subject you to the sound and the sight of me sniffling. So today, and thank you, Sonali, for the kind introduction as well as for this opportunity. Today, I sort of want to talk a little bit about AI and its applications, but also its opportunities and its challenges, particularly in healthcare, right? But first, I think Mount Sinai is one of the places which has been at the forefront of the revolution of AI in healthcare, and that has led us to be number one in the world on AI as by a recent Nature Index. And thanks to David Windreich, who's a friend and partner now. We have a philanthropically funded department, the Windreich Department of AI and Human Health, which is the first department in the country. And this is thanks to our school and health system leadership, predominantly Dean Eric Nestler, who just became the Dean of the Icahn School of Medicine at Mount Sinai, uh, Dennis Chani, who is my mentor and a former dean, and Brendan Carr, who's also a mentor and the CEO of the health system. So, but before we sort of talk about AI applications, I think it's sort of good to ground us in the history of AI, right? Because we don't know where we are going unless we know where we came from. And it also gives us certain opportunities to avoid mistakes of the past, because even if history doesn't repeat itself, it certainly rhymes. And sort of with that in mind, you know, if you were on Earth, dropped on Earth in November of 2023, you would be forgiven for thinking that AI has been invented in October of 2023, and that's because of the advent of ChatGPT and chatbots like such. But the opposite is true, right? AI has had a long and illustrious history, intertwining between computer science, mathematics, medicine, from the 75 years back, because it was in 1956 that John McCarthy actually coined the term AI, or artificial intelligence. In 1964, there was a rule-based chatbot using punch cards, which was developed at MGH. It was called as Eliza. It was 26 years back at this point of time that the mathematical and the computer science foundations of what is modern AI today were laid by Geoff Hinton, Yoshua Bengio, and Jan LeCun. And Geoff Hinton recently won the Nobel Prize for this pioneering work. And if you want to look at more recent things, 8 years back, FDA approved the first cloud-based deep learning application for mapping coronary artery calcium burden, called Arteris. And so AI has been around for a while. But most importantly, I sort of want to point out to this period of 1970s and 1990s, where there was a technological innovation and there was a lot of interest, and hype went up significantly, and obviously the technology couldn't live up to the hype. And as a result of that, public funding, government funding, industry funding for AI sort of plummeted off a roof, or plummeted off a cliff. And that was the period called as AI winters. And we should take some lessons from those AI winters, because hype cycles are as old as humanity itself. But at the same time, it's important to realize what technology can do and cannot do, and sort of modulate your expectations accordingly. So why are we talking so much about AI right now, right? And I think that if you break it down, there's predominantly three reasons. The first reason is digital data, and that's a function of the world writ large, right? More and more data is digitalized as we speak. And if you just think about your own personal life, right? From the time you get up to the time you go to bed, how much time do you spend generating, consuming, or otherwise interacting with a digital device that all feeds to this giant data that we have, right? And healthcare is no exception, right? Healthcare is becoming increasingly digitized. The second is computing power, and there's a reason that Nvidia has reached a market capitalization of $5 trillion yesterday. It's because of chips like this, which are called as GPUs or graphic processing units. So interesting fact, these GPUs were not meant for AI in the first place. They were meant for playing computer games, and that's why they were designed with doing to do trillions and trillions of metric multiplications, which is required to sort of when you're playing computer games. And then Nvidia had the great idea of repurposing them for AI. Computing power has I think the amount of computing power just that has been created in the last year is much more than was created, exponentially more than was created in the history of mankind, and it will continue to grow. Now, there is environmental and other issues which I will not talk about because it's a topic of another hour talk. And finally, it's just public interest and public perception of this, right? So this is a chart showing how long it took for different technologies to reach 100 million users, and Google took approximately 7 years to reach 100 million users. ChatGPT did it in 2 months. So AI has sort of become embedded in the public lexicon, and because of this combination of immense digital data, a large amount of compute power, and the fact that it's now embedded into our sort of culture as a species, I think that's why we're talking about so much about AI right now. And healthcare is no exception, right? Healthcare generates an incredible amount of data on a daily basis. So if you are a clinician, think about just on one patient, you order labs, you write notes, you order imaging, you order ECGs, you order X-rays, etc., and all those that is digitized and is data. So healthcare, in 2020, and we could update this slide because it's growing exponentially, is generating exabytes of data, and an exabyte is a billion gigabytes. So it's just to give you a benchmark of it, it's equivalent to 3 million years of IMAX quality video, that much data. And Mount Sinai, thanks to Patricia Kovacs, who's a partner and the Dean of Scientific Computing at Mount Sinai, has this program called as AI Ready Mount Sinai, and I'll show you an example where it was used, which is a platform where we can access the vast data sets which are all linked together. There's also been a hyper exponential rise in computing capacity, right? And Mount Sinai has been leading in that with the largest academic supercomputer among all academic centers. But also, New York State has this interesting and transformative program called as Empire AI, where it's a unique governmental academic partnership, which is building the largest supercomputer to levels with companies like Meta and Google. And finally, I think it's important to talk about AI. We need to talk about transformers, and transformers is the T in ChatGPT. Most lay people think that transformers were invented by OpenAI, and that's not true. Transformers were actually invented by Google, and this paper, which came out in 2018 or 2017, is probably one of the most scientifically important papers ever to come out on the planet, because it sort of invented and led to the concept of attention, which is the backbone of all modern AI systems using transformers, and also has to take the title for best paper title ever, which is saying attention is all you need. So I think it's important to talk what is attention, right? And its attention can be explained in the form of language. So if you just take a single word called as bark, right? No context, nothing. If and then you put it into a sentence. So the sentence on the left says the tree bark is brown, and in this case, bark is being used to describe a feature of the tree because it's associated with a tree and it's associated with a color. While on the right side, the bark is being used to associate with the sound of an animal, right? Because it's associated with a function of sound as well as associated with an animal, right? Now, before transformers, programs would have significant difficulty in understanding the context of individual words. They would have looked at bark and thought this bark is the same as this bark, but as a human, you can read these two sentences and understand that they are quite different, right? So if you think about just the word bark, right, you can take all of the English language, all of the words in sequence in the English language, and see where bark falls, right? Now, if bark falls in terms in, with leaves and flowers and twigs, things that denote a particular tree, you would, and it's co-localized with them in vector space, you would probably, the program would learn that this bark, because it's occurring with things related to a tree, means a bark of a tree, while this bark, because it's associated significantly with animal sounds, is associated with a bark of a dog, right? And that is, in a nutshell, what attention is, right? It's the statistical relationship and the co-occurrence of every word in the English language compared with every other single word in the English language, right? It's the statistical probability that when bark appears with like tree and brown, it means a tree bark, and the statistical probability when bark appears with dogs and a function of sound, it means a dog bark. And that simply is transformers, right? Because transformers is what, given the statistical distribution of words in the entire corpus of mostly English language, what words are most likely to follow a particular sequence, right? Because now it's been pre-trained on this large corpus of language. You can tell it that it will auto-complete it for you, right? The first person to walk on the moon was Neil Armstrong, because it's seen this pattern again and again and again in the English language. And that's what it's important to understand for transformers is, or large language models, is that they generate statistically likely sequences of words, and words are called tokens because one word is one token for pre-training. They don't really understand text meaning in a literal sense. They understand the statistics behind it and the co-occurrence of words behind it. And this is what a transformer looks like, right? This is the encoder, which is the embedded sort of statistical relationship of all of the words, and you put it in an input, and then it just predicts the word after that and the word after that and the word after that until you have an output. And that's what basically a transformer is. This is a complicated computer science diagram, but basically it's taking a sequence of words and it's generating the words after that. And that's what a GPT is, right? It's a transformer because that's the architecture of the AI model behind it. It's pre-trained because it's been like trained on trillions and trillions of words in the English language, and it's generative because it's generating the next statistically sequence of words. And that has led to the concept of a foundation model, right? And I've been doing this for ML and AI for a while, and I remember the time when if you wanted to build a ML model for text, you had to pick a model, you had to train the model, and then it performed a task. But then if you want to build one for tabular data, you had to pick a model, you had to train the model on the tabular data to perform the task, right? And so on and so forth, because it was individual siloed models. It required task specific training and lots of human supervised training. But now it's given the concept of foundation models where, all of this different data sets, all of this different digitized data has been sort of used for pre-training, leading to this foundation in which you can actually just prompt it and it can do a variety of tasks for you, right? Like GPT-5 can write a poem, it can complete an essay, it can write a recommendation letter. You don't need to train an independent model for it. And when you have specific proprietary data, you can just fine tune the model, which requires much less effort and much less time and much less energy to, as opposed to training a massive foundation model. And then you can complete a variety of other tasks. So a foundation model is at its core a massive multitasking model, which is adaptable with little or no training. And because it's pre-trained on massive troves of data. And that is one promise in healthcare, right? Because healthcare is also a multimodal data system at its core, right? If you think about what inputs go into your health, I'm not going to read off anything, but you have obviously your genome, but how your genome interacts with the environment. You have your immune system. You have your what medications you take, what habits you have, how you sleep, right? And all of that has to put into context of medical history, but also the world's medical literature, which is constantly being updated at a pace which is almost impossible for physicians to keep up with, right? And that is where the promise of this is, because you can use all of this data to sort of you do self-supervised training, linking all of these different data types together, and then link it to literature, publications, clinical notes, etc., etc. And that is the promise of AI in health. Is, in my opinion, in a nutshell, is that it's automating or augmenting data and information processing tasks, because healthcare is, you take in information and or raw data, and then you make a decision. But like, we've forgotten, as a clinician, we've forgotten health, the premise of healthcare, because instead of using data to make better decisions, we are in the unenviable position of generating more and more data. And what do I mean by that, right? As a clinician, if I see a patient for like 20 minutes, I might talk to the patient for 7.5 minutes and spend the remaining 12.5 minutes writing my note, which is basically data entry into an electronic health system, right? And that sort of AI, one promise of AI is, instead of making us work for the data, it's making data work for patients, most importantly, but also providers and systems, because it can, if you are thinking of an AI model as an embedded compressed knowledge core, it can take in raw data, whatever that raw data might be, and turn that into desired, in actionable information, right? Be it diagnosis, be it prediction, be it summarization. And I'll give you examples of each one of these in applications. So just moving on to applications with that premise in mind, right? I think I'm going to talk about applications in sort of three buckets, right? The first one is obviously the clinical bucket, right? So Mount Sinai has been at the forefront of this, thanks to the leadership of David Rich, who is the chief clinical officer and the president of Mount Sinai. We've deployed over 15 products at enterprise scale with over 10 million predictions a year. And these are some of the examples, and I'll go into one of them in detail, right? So I just want to give two examples how this could impact patient care. And this is an example of a story about a baby in a neonatal intensive care unit who had actually a spinal cord bleed. And that bleed just led to this twitching of the leg. And this was too subtle to detect by humans or by current technology, because you can't have a human watching a patient for 24/7. Humans get tired, and it's just not possible, right? And despite neurosurgery and optimal care, the baby had permanent paralysis, and that led the inventor of this technology to think, could AI have detected the changes sooner and changed the baby's future, right? And that led to the creation of the Artemis AI engine, which is because neurological injury is devastating but cannot be predicted currently. But if you think about video AI technology, anyone who drives a self or uh, not full self-driving, but a self-driving car knows how good they're getting. And we developed and validated this AI to predict neurological injury in babies. So this is an example of a pre-trained model being used for pose recognition. It can map out anatomical landmarks and then constantly monitor for changes from the baseline. And you can see here that this is on retrospective data, but the you can detect sort of deviations from the baseline. And when you benchmark it against human diagnosis, it has an AUROC of 0.89 on an independent validation data set. And most importantly, I think it can detect neurological dysfunction much earlier than humans could detect. For example, with video AI detection, you can detect it approximately an hour and a half to 2 hours before humans can detect. And this is an example of when AI is an arbitrage of knowledge for time, right? Because it's giving you enough time for a clinician or another provider to make an actionable decision that can actually change the course and improve outcomes. This work has all been done by a team of dedicated clinicians, scientists, and leaders. And they are deploying this in a prospective trial across a NICU net to deploy computer vision AI in every NICU incubator. And this has been done, work has been done by Ben Glicksberg, who is the founding director of Child Health AI within the health system, Felix, who's a neonatologist but also a computer scientist, and Bruce Gelb, who's the dean of child health research. And these are all of our partners where we're deploying this video AI in the form of a prospective clinical trial across the country. The second example I want to talk about is heart failure, right? And for those in the audience, heart failure is one of the most common condition. It's a condition in which the heart wall thickens significantly, and because you don't have space to push the blood out, you can't push the blood out, and it leads to sort of backing up of the blood. It causes you not to breathe, legs swell up, it's really hard to live, and it's a major problem because it's responsible for many thousands of deaths, hundreds of thousands of deaths in the United States. And it affects around 6.2 million adults in the US, and the yearly cost is 31 billion. But sorry. But most importantly, it's extremely misdiagnosed. So the rates of heart failure misdiagnosis range from 1 in 6 in hospital settings to 2 in 3 in the community settings. That's because of many reasons. One reason is that the technology for diagnosing heart failure, which is called a cardiac echo, it's expensive. It requires expert interpretation, and it's not available everywhere. But you could use a simple ECG, which all of us have gotten at one point or the other, or even if you haven't gotten it, if you have an Apple Watch or a Whoop or a Fitbit, you can take an ECG right now. You can use that to draw ECG signals to actually classify heart function accurately. So this was a study that we did where we paired sort of ECGs, raw ECG data with echoes for diagnosis of heart failure in over 150,000 patients, leading to 3/4 of a million echo ECG pairs, and we ran this through a transformer network. So you can actually classify left ventricular ejection fraction, which is a marker of heart failure, extremely accurately with an AUROC of 94%. But you can also get to the actual numerical value of the LVEF within like 5 percentage points, which is reasonably accurate and is actually better than a human reader. And you can do that the same for right ventricular systolic dysfunction as well. And most importantly, it has no different performance in women versus men, whether you're old or young, whether you are black or white, right? It has the exact same performance of by age or sex, by race or ethnicity, whether you're female or male. So there's no bias in this. So I just want to show you how this is operationalized. This is a dashboard that we created where anyone you can log in, and it's usually used by physicians. And you can just type in the MRN of any patient that you want, right? Within the health system. All you need is the MRN, or actually the name, and it'll pull up all of the ECGs of the patient, and you can just click on any ECG, and it will tell you whether the risk of heart failure, in this case, low ejection fraction, is high, if the patient has aortic stenosis versus not, the patient has COPD versus not, and PVC cardiomyopathy, and we're constantly adding new models. This is kind of already out of date, because as soon as we validate a new model, we can add it in. Okay, I just want to briefly touch upon sort of research, and not sort of AI research per se, which a lot of this is, but AI to sort of augment and improve the way that we do research, right? Because if we think about the life cycle of the research, it involves a lot of paperwork, right? And it involves a lot of manual things. So if you think about like the number of steps in any clinical study or a clinical trial, right? starting from study design to setup to try the actual trial to supply to data management, analysis, and finally FDA submission, right? It's a lot of paperwork and it's a lot of logistics and a lot of documentation. So if you use generative AI to create scalable processes to augment and enable research, the argument is that it would make this time consuming processes much more efficient and free up investigators to do more creative thinking as opposed to more paperwork, which is another play on sort of arbitraging knowledge for time, right? In this case, you are arbitraging the knowledge embedded in large language models to free up time for investigators. So one example of this is sort of automating the clinical trials recruitment pipeline, right? So we integrate with electronic health records to scan patient notes, use LLMs to flag potential eligibility and generates a ranked score. Anytime a new trial comes in with the trial name, inclusion and exclusion criteria, it goes into a REDCap database, which is integrated into the EHR, and it generates an output with patients most likely to meet the criteria and what the reasoning behind was. So we've deployed it for, I mean, now it's like live across the Department of Medicine with like 40 trials thing. But we deployed it first for ulcerative colitis and Crohn's disease trials. And the trial enrollment in a month went from 0 to 12 for this particular trial and from 1 to 5 for this particular trial. And all this work was done with Eyal, who's the chief of generative AI in our department, Monica Kraft, who's our chair of Department of Medicine, and Amelia, who's the chair of the Clinical Trials Institute. So then finally, just talking about people, right? I think AI has a significant role to sort of alleviate documentation burden because if you think about it, a lot of people are leaving healthcare right now because they feel burnt out. And while obviously not the only reason, one of the big reasons is that frontline healthcare workers feel burnout related to the amount of documentation. And that's where ambient AI can actually help. And because it's anyone who's used it, it's a great tool, right? Because you just talk to the patient and you have more time talking to the patient, and by the time you're done, you have a fully formatted coded note ready. And there's we did a systematic review on sort of the early experiences with ambient AI, and with burnout, emerging evidence suggests a positive impact on burnout, improved cognitive load, improved quality of notes, and improved patient experience, right? Because I think patients feel that the physician is spending or the provider is spending more time talking to them as opposed to like more time typing into a computer. And the second sort of flip side of that is coding, right? Because you know I learned coding almost as an afterthought in residency, right? It was not my primary focus. But, if coding is basically like reading a note and figuring out what was done and assigning it appropriate codes, LLMs can do that much better, right? So this manuscript was just published in NEGM AI, and here we did like almost a randomized trial of human versus GPT-4, but we did a bunch of other LLMs uh, by accuracy. And here you can see that even by when arbitrated by attendings, humans actually got LLMs won many more times. When I say one, I mean in terms of accuracy and sensitivity, specificity compared to humans, right? And that makes sense, right? Because coding is not something that physicians are extremely trained to do, but it's something that would be you can move off your plate again to give more time for actual clinical care. The same thing is around this what we did with operative post-op complications engine, right? So earlier, this is a QI initiative. Anytime you have you have to randomly review a number of your charts after surgery to see if they have complications, because that's a part of a reporting standard to NESCRIP and other things, right? And before AI, residents were doing this in their spare time, like going combing through notes, right? But we created this ML classifier to identify complications of the surgery, generate the report, and just it goes into the M&M repository, right? And we found that compared to humans, AI identified many more complications. So that gives you an opportunity for quality improvement, but it also had much fewer false negatives as compared to humans, because I mean humans get tired, right, of reading notes. And there was a high satisfaction rate of the generated reports when evaluated by the QI folks. And again, this is a good use of AI for sort of administrative work, because now all of the time that the residents have spent doing this could be given back to them for other things. So I've given you a few sort of applications of AI, but I sort of want to spend the remainder of my time starting off with challenges and opportunities, right? And the first challenge is the healthcare AI paradox. And the framing of the healthcare AI paradox is simple. So on the academic side, we do a ton of research, publish a lot of papers. None of that gets integrated, or none of that gets, or very little of that gets translated into the clinical and operational side. And on the clinical and operational side, we're developing a lot of stuff, or deploying a lot of stuff, but none of that ever gets researched. So we are in this interesting paradox, as coined by my friend Karandeep Singh, that we none of what we research gets implemented, none of what we implement gets researched, right? And why is this? And there are a few I mean, it's a multifactorial complex problem, but there are a few reasons, right? And this problem can be summed up as best as a leaky pipeline problem, right? So you are a fresh-faced AI scientist who wants to develop a model for something, right? Right at the bat, that model will never be deployed into clinical care because it was developed on the wrong patient population or for the wrong problem. It was used non-available predictors that are not really used in clinical care. It's too time intensive to use that approach as opposed to not use that approach, and the outcome just keeps on shifting more and over and over, right? So you're not really sure. And sepsis is a great example of that, because sepsis has 5 different definitions, and the things that clinical and operational people care about in terms of outcome are not the things that research people care about. But suppose you get through this hurdle, right? You develop a fit for purpose model. Second problem is no validation, right? You have no temporal validation because there's lack of data or incentive to produce validation studies. No one can validate the model because it's incompletely reported or overfitted, or there's proprietary and you don't want to make the data public, right? Even if you get through validation, there is no implementation because there is no impact on any ROI metric like decision making or patient outcomes or financial ROI. People don't know how to implement or use the model. There might be some regulatory requirements depending upon the use case of your model, and it's too cumbersome to use. Finally, you manage to get it implemented and you manage to get it in front of people. It's not adopted, and it's not adopted predominantly for the reason is like, no one asked for this. Why didn't you talk to us before developing this model? Or people don't trust the prediction, or it's not transparent enough or interpretable enough, or it's perceived as outdated. And this is the problem in academia, right? Like trying to take a academic research model all the way to implementation and adoption. But you have the opposite problem in industry, where all of your clinical and operational folks are dealing with this deluge of AI models coming from industry with no evidence behind them. And in my sort of operational role, when I ask like what is the evidence that it does something actually good, they show me a really nice PowerPoint presentation. So I mean, again, we do a lot of research, none of it gets implemented or adopted, and we do implement a lot, none of it gets researched. And this problem is sort of compounded by the fact that there is no rigorous testing of AI, right? So some of you might remember the Epic AI sepsis issue, where Karandeep Singh actually did a validation on a widely deployed sepsis model and showed that the predictive performance of that model was the AURC was in the 50s, right? Almost as equivalent to a coin toss. And Epic had to like revise this model, but like my argument is, why wasn't an validation done before? And the problem is there's no incentive for doing like rigorous testing of AI, right? This is exemplified by the fact that this was a review from last year, which showed the number of clinical trials around AI until 2021 that have been reported have been 15, right? mostly in gastroenterology, some in cardiology, right? So I think there needs to be an increased emphasis on rigorous testing of AI, because ultimately you're using this to make clinical decision and change health outcomes. So I think one way to think about this, and this has been talked to me by Nick Gavin, who's one of the chief clinical innovation officer, is start with the why, right? Why are you doing this? Why are you developing the model? Identify problems that people agree about and are potentially tractable, right? And the only way to do that is to talk to the people who are ultimately going to make the clinical decisions informed by your approach, right? And these are frontline providers. But also make sure that it aligns with institutional goals, right? Because the frontline provider might have one problem and the institution might have another problem, and if you find that Venn diagram, then it's almost a guarantee of adoption, right? And do an opportunity analysis so that you can say that if you develop this model and everything goes well, this is the sort of opportunity that we could see from it, and then only develop the model to make sure it's fit for purpose on the patient population where it will be implemented. Test the approach, and you don't have to do an RCT for everything. You can do a silent pilot, a workflow analysis, see where it would fit best, but test the approach, right? Don't like blindly implement it. And then do the after you deployed the model, then the job is not done. It's not fire and forget or set and forget, right? You have to think about data monitoring, workflow monitoring, data drift, all of those things, and that's a separate conversation altogether. And then think about how you're going to evaluate it in terms of, have you reduced costs, have you improved outcome, have you optimized care pathways, are people happy using this approach, right? Because that's a guarantee that people will continue using it. So the second problem I want to talk about broadly is bias, right? And bias is sort of an issue that uh, is pervasive, for lack of a better word. And the reason that it's pervasive is because we live in a world that is biased, and there's real world patterns of health inequality and discrimination that sort of make its way into our data. And then we use that biased data to design AI and predictive or generative AI. And then we use that AI in order to make decisions, clinical decisions, which further lead to bias, which further lead to a biased world, which further lead to biased data, which further lead to biased design and biased use, leading us in this unvirtuous cycle from hell, right? And I'm just going to give you an example how this plays out in the clinical scenario, right? So again, this work was done by EAL. So we basically ran a very simple experiment at large scale, right? We took 500, we generated 500 clinical vignettes, and we took 500 triage notes from the Mount Sinai Health System, and two board certified physicians read through every vignette and every case to make sure that it was like legit and not like a zebra, right? And for each case, and we did this with a bunch of different models, for each case, the model was just asked to answer four questions, right? How sick is the patient? So triage priority. What further testing would you recommend for the patient, whether invasive testing or not? What treatment approach will you take for this patient? And whether this patient will need a mental health assessment, right? And then we just did one thing. Instead, we kept the clinical case the same, but we just changed the sociodemographic indicator of the patient, right? So from straight patient, the patient became gay, lesbian, or non-binary. From white, the patient went to black. On from rich, the patient went to unhoused, right? For the same exact clinical case, nothing changed in the clinical case. And the results were startling, right? Low income patients, unhoused patients were recommended less advanced testing, even though they needed it. And high income patients were recommended increased advanced testing. Homeless patients were recommended mental health assessments and hospital admissions, even if they did not need it. Transgender individuals and bisexual individuals were automatically recommended mental health assessments, even if they did not need it, which sort of indicates like that that the model over-indexes on demographic characteristics as opposed to clinical characteristics, and that's like dangerous, right? Because you could have the same clinical case, and if you just change white to black, you could have a completely different treatment recommendation. So how do you address this, right? So I think you need a multi-level strategy to address bias, and that's a topic of another talk. But I just want to think about going to the data, and we have this AI guided data strategy to identify bias at the data set level, at the root cause, right? And it's called as equity, and it can detect and qualify what kind of bias it is. And NIH is sort of working with us to apply this to all of your data sets. So before you can start building the models, you actually know what their bias is and take steps to prevent that. The second thing is hallucinations, right? And I just want to quickly say a word about hallucinations. Like if you remember earlier, LLMs are incentivized to complete sentences and complete paragraphs, right? There's no requirement that that completion be true. It is drawing upon its vast trove of data, mostly driven from the internet. And as you know, internet is like half truth and half whatever it is, right? So basically, we ran a simple experiment, right? We generated 300 cases, like short and long cases, verified by physicians. But in every case, we like inserted one fabricated detail, right? Like a fabricated lab value or a fabricated clinical condition or a symptom or a sign, and then sort of ran the LLM and uh, we wanted to see how long the LLM took to actually catch up that the fact that this does not exist, right? Like for example, these things don't exist, like cervical dual line sign, mesenteric lattice, just it's like bingo, they don't exist. Um, and we just want to see how long the LLM perpetuated this, and the results are like startling. Regardless of the LLM type, be it GPT or DeepSeek or whatever, they just kept repeating the same fabricated detail again and again, like 40 to 50 to 75% of the time. And even if you told the LLM that this is fake, don't repeat this, it still it decreased it, right? It decreased it to 40% from like 70%, but still like 40% of the time it just kept repeating the fabricated detail. So hallucinations, especially what is called as induced hallucinations or adversarial hallucinations, is a big problem with LLMs. Then finally, sort of lack of transparency is endemic, right? And this is because most of the large models are coming from industry, right? Like this was this paper from Science, I think last year, which shows that indication industry is leading in publications, biggest models, AI benchmarks, right? And we don't know how these models are trained, what labor was used, what compute was used, what methods were used, right? I mean, it's predominantly read across the board, right? And that's why we need to like have more transparency into if these models are being used for actual clinical healthcare decisions. So how do you sort of think about these challenges and risks, right? I think, first we need some regulation around this, right? And that needs to happen at like the state or the local level, because federal, the center is not making, the federal government is not making regulations. Then we need a good governance process in place for health systems in order to make sure that anything we deploy into care is safe, effective, and ethical. We need rigor at the implementation level, right? So we actually know what is working and we're not just burning compute credits. And then finally, we need transparency in all levels, right? Like, patients need transparency, physicians need transparency, scientists need transparency, health systems need transparency at all levels, right? So I just want to sort of give a plug for Mount Sinai and Lisa, who's the Chief Digital and Information Officer. So we have a pre-triage form where we evaluate this, where we validate it with a proof of concept, and then deploy it, and then ensure that there's quality assurance. And the model can be pulled from point A, from circulation at any of those checkpoints if it doesn't meet the pre-approved criteria. All right, and the last thing, before I end and take questions, is sort of this review that we wrote, right? And machines are not even close to exceeding us at this point. We're not even close to ASI or AGI at this point of time. But just the thought experiment, right? What happens if they exceed us, right? And have we made healthcare sort of human-centered and human-led, as opposed to being not human centered and human led, right? Have we hard coded those rules into our healthcare system? And this is a good, good time for us to take stock of healthcare in general and maybe think of it as an inflection point where we ensure that all of healthcare is human centered, unbiased, ethical, and as responsible as possible, not just the AI that we deploy into healthcare, right? So with that, thank you, and I'm happy to take questions.
Thank you very much, Dr. Nadkarni. This was very informative and you covered a lot of different viewpoints, and I really liked how transparent and how understandable all your slides were. I'll open it to questions now. So while people are thinking, I have a question. So how are things set up at Mount Sinai in terms of your like data scientists or researchers or clinicians? How do they all interact with each other, and which are some of the features, or which do you think are your strengths to be able to implement all these models and actually successfully use them for patient benefit?
Yeah, so I think anyone can come up with an idea to the health system. We've created a portal where people just need to describe their idea. There's a central group of data scientists that work in DTP, which is our IT department, and the department that works on problems for the health system. But again, it has to align with like health system priorities, but also clinician and other provider priorities, right? Now, obviously, there's a fair amount of decentralization as well, where people can like work on models throughout the health system. But if they have to be implemented into care, they have to meet sort of the benchmarks as well as the checkpoints of the AI governance.
Awesome. Thank you. Anyone else has questions? So Emma has posted a question in chat. How have patients felt about these AI implementations?
So that's a great question. First of all, we're very transparent with the patients in the notice of privacy and the front door consent that AI may be used as part of the clinical care. But again, it's human led and human centered, and all humans are making the decisions. So we have had multiple focus groups around patients around this, and we also are in the process of forming a community advisory board to guide sort of AI strategy and implementations within the health system. And overwhelmingly, it's been positive. Predominantly because patient satisfaction increases when physicians are paying more time to them. So ambient AI has been a big hit, and that's predominantly what they feel like. But also in terms of like in terms of generative AI responses, etc., would be patients feel positive about that. And again, we try to be transparent with what's being used, how it's being used, what are the performance metrics, etc. I think patients appreciate the transparency. But again, we treat like millions of patients a year.
Thank you, Dr. Nadkarni. Poonam has a question. What skills or training should, and do you want to unmute yourself, Poonam? Okay, so yeah, what skills or training should healthcare professionals prioritize to work effectively with AI systems?
I think that skills that healthcare professionals should prioritize are communication skills, because I think that is more relevant in this day and age of AI systems, right? When knowledge has become slightly democratized. But at the same time, you should prioritize sort of your critical thinking abilities, because one of the roles that healthcare will have is to sort of flag incorrect or catch incorrect, be the line of defense against incorrect AI inputs that can translate at scale, right? But obviously learn how to work with generative AI in terms of like prompt engineering or just prompting, right? That's basic skills. But I think the important skills that we need are to uh, uh, prevent de-skilling and mis-skilling with AI augmentation, and that's why critical thinking and communication become even more important.
Thank you for that. We actually had another talk earlier today with the Deep Learning Affinity Group where this topic was discussed. And what was most interesting was that sometimes this descaling or over reliance on AI systems was dependent on different demographics. So there appeared to be some sort of a confidence bias in terms of different demographics descaling or relying on AI in different degree. So that was also fascinating. Any last questions before we close? Thank you again, Dr. Nadkarni, very
Thank you
much.
so much, and it was great talking to you all, and have a wonderful day.
This was great. Thank you. And I'll post this on YouTube and share the link. Thank you everybody for joining and hope to see you next time. Bye.